Good afternoon. Good afternoon. This is the Appropriations Healthcare Subcommittee, and I apologize for my tardiness. We've got meetings backed up to back up to back up, so happy to have you here, and we're looking forward to hearing from you. Before we begin our meeting, Chairman Ron Stevens, would you offer a blessing?
Be honored. Would you pray with me, please? Most kind and gracious Heavenly Father, give us your wisdom and your ways and your guidance to do the things in your will, and make sure that we're doing the things in your ways. All these things we ask, amen.
Thank you. We appreciate everyone being here today, and we look forward to hearing from you and from the departments. If you would, hearing right now, we'll begin with Department of Community Health. Do you want to go to the table?
And Brian, our budget manager, will control slides for us.
Thank you. If you would introduce yourself.
Good morning, Madam Chair. I'm Kaylee Noggle, afternoon, actually, Commissioner at the Department of Community Health. So today we're going to review the Governor's FY24 budget recommendations. A couple of slides just for re-education or for new members, just a little bit about the agency and an overview. We've got about 600 staff, mostly based out of Atlanta, either currently in our office at 2 Peachtree. We have an office in Cordele, and then many of our members are remote because they're out and doing compliance activities. We compiled a little bit of information for you on slide 3, some just updates for you. As of February 1st, we had 608 full-time equivalent employees, 167 vacancies across the department. Our year-to-date turnover rate is 10%. In FY22, in total, it was 18%. So we are trending in the right direction there. We are eternally grateful for the governor's leadership and recommendation of an additional $2,000 COLA for our employees. In total across our programs, that's just under $920,000. We'll match that with other fund sources. Our total cost to implement that is just over $2 million for our agency. And then we included a little bit of information about agency user fees at the bottom, so you can see how those are collected and retained or spent by the agency. On slide 4, just a refresher reminder, our FY23 budget, how it's spent by program. Our base budget is $4.4 billion state dollars, 18.2 when you include federal and other funds. Again, you can see most of our expenses are either in the Medicaid program, either age, blind, and disabled, which has more expenses but fewer members, or our low-income Medicaid, which is mostly pregnant moms and children. If we move into the actual budget, we start at section 17 on your tracking sheet. So I'll go through those items for you. At 17.1.1, and the next few numbers are all statewide changes. So the cost of living adjustments and normal DOAS, TeamWorks, and merit system billing. So I won't really comment on most of those for each of the programs, but those are there. At 17.1.5, there's a reduction of $6.5 million. These funds were added in the budget last year to support a Medicaid Management Information System transformation, a project that those funds were disregarded in the budget, in the governor's final budget version last year, and so this is recognizing that disregard and a reduction from the budget here. There were one-time funds for a mental health care reimbursement rate study that we conducted last year, so it's a reduction of removing those one-time funds from the budget at 17.1.6. And then at 17.1.7, there's a transfer of $800,000 from our department over to the Office of Planning and Budget and the Office of Health Strategy and Coordination. The Office of Health Strategy and Coordination existed in statute prior to it existing in budget. And so for the last couple of years, its program funding has been at the Department of Community Health. It is an independent budget item now, and so this recognizes transferring their funds back to that appropriate entity. 17.2.1, the Georgia Board of Dentistry. These are statewide changes only. 17.3.1 is the State Board of Pharmacy. Again, just statewide changes. 17.4, healthcare access and improvement. Again, statewide changes only. 17.5.1, healthcare facility regulation, only statewide changes. At 17.7.1, we do have a number of items, and this is Medicaid, age, blind, and disabled. The first is an increase of $79 million for Medicaid growth based on projected utilization. As you're all pretty familiar at this point, our Medicaid rolls are very inflated right now because of the public health emergency and the continuous enrollment requirement. So we're sitting at about 2.7 million members, which is significantly higher, almost 25% higher than it was pre-COVID. So this is the cost to continue to carry those members. At 17.7.2, $102 million due to an adjustment in our FMAP percentage, which is our federal cost share. Last year, the matching rate was 66.02%. That goes down to 65.89% this coming year. That adjusts annually, a number set by the feds. And so as their portion decreases, it means that we pay more on the state side. So that's an $102 additional million to support that change. 17.7.3 and .4 are annual true-ups, the Medicare Part D clawback and Medicare Part B premiums, just a true-up between federal and state funds. $465,000 as a yes item to replace general funds with hospital provider fees. That's a general true-up as hospital provider fees are swapping out state general funds since those are earmarked for those purposes. At 17.7.6, there's an increase of $8.7 million. That's recognizing ambulance provider fees that the department has begun collecting. If you'll recall, HB 271 during the 2021 session created and allowed the department to start collecting a provider fee for certain ambulance providers. That program has been implemented for private 911 ambulance providers. We'll use these provider fees, $8.7 million, to draw down additional federal dollars, about $20 million, bundle those numbers together, and send out about $28 million to these 30 ambulance providers around the state that are private 911 providers. At 17.7.7, it's replacing $9.7 million in nursing home provider fees with state general funds, and that's an annual true-up. And 17.7.8, a yes item to use $82 million in existing funds to update our cost reports to the 2021 version for our skilled nursing centers. Their rates are based on annual cost reports, and last year there was language in the budget that we should begin updating those to every year. We had been pinned to about a 2012 version of the cost report, so their cost reports were lagging in terms of what was reported and what we were basing payments off of from actual costs, and so this is keeping up with their current cost reports annually. And then at 17.7.9, recognize $74.6 million reduction from HB 81 during the 2021 session. Essentially what's happening here is there was a cut to our base budget a couple of years ago during COVID when those funds were not needed. We expect to see savings in FY24, and so this just recognizes that it's really a wash and gets us about back to starting point. And you'll see that again in a couple of other programs. At 17.8.1, we're into the low-income Medicaid program. Again, the FMAP adjustment, where the federal cost share is going down a fraction of a percent, but it causes an increase of $115 million in state funds. The enhanced FMAP going from 76.21 to 76.12, an additional cost of $1.9 million. That similar recognition of a cut that was made in the 2021 session of $52 million. A true-up with state funds and hospital provider fees at 17.8.4. And then the recognition, again, of $74 million from 2021 at 17.8.5 as a yes item. Peach Care, again, some FMAP reductions, $17.2 million to account for the decreasing federal cost share. And that same yes item recognizing the reduction from a couple of years ago, but acknowledging that we'll likely have savings in the coming year due to continued FMAP beyond the end of FY23. So that will provide a little bit of savings there and balance that out. At 17.10.1, the State Health Benefit Plan, we've talked about this program a number of times and in joint together. At 17.10.1, an increase of the employer contribution per member per month for certified school employees. We're currently billing at $945 a month per active employee. This changes that employer rate to $1,580 per month, which results in $846 million in revenue to the State Health Benefit Plan. There is a corresponding budget item in the Department of Education for this line item. At 17.10.2, it's also increasing the per member per month rate for non-certified school employees to the same rate. which results in an additional $228.9 million in revenue for the state health benefit plan. In the amended budget, there was some additional money placed, one-time funds placed in the amended budget, and so I would expect that there will be further conversations about this line item going forward in the coming weeks. And then just the summary, and there's a lot of movement between FMAP money moving in and moving out, but total net state funds of $373 million, and then considering the federal funds on the next slide as well, it's about $1.4 billion increase as recommended by the governor. Happy to take any questions, Madam Chair. I also have some additional slides attached related to the directed payment programs that we've talked about a number of times. I'm happy to walk you through those today or at another time, but they are there for your information as well.
I don't see any lights up. Well, yes, we do. We have one. Representative Hughley?
I'm sorry, Madam Chair, late on the light. Thank you for the presentation. The thing that I guess concerns me more than anything else is the recertification when we do this unwinding of Medicaid. I know that that's not necessarily your agency, but it's going to affect your numbers here. Can you give us an opinion about how you think that's going to go? And
Sure. I'm very optimistic. So we work in partnership. DCH is a single state Medicaid agency, so we're ultimately responsible for all of that. Our sister agency in the Department of Human Services and DFACS acts as our partner and our vendor that actually will do the manual labor, the recertification and redetermination of, and they have the single integrated eligibility system that their staff will be doing the member outreach to ensure that we're taking care of all those members. I think over the next couple of years in our budget and our membership roles, you're going to see a lot of changing numbers. So as we start to collectively, as health agencies together, redetermine eligibility, we're expecting that a number of members will lose eligibility. By federal design, this continuous eligibility requirement is ending on March 30th. So members that no longer meet the income or other eligibility requirements, when it's their turn to have their eligibility redetermined over the course of the next 12 to 14 months, will be evaluated, and several 100,000 of them, in all likelihood, will lose eligibility. What we're hoping, though, at the same time, you've heard us talk about the governor's, one of his key healthcare initiatives is the Georgia Pathways to Coverage, an 1115 demonstration project, which is limited Medicaid expansion for folks that are willing to complete a qualifying activity. So work, education, job training, volunteer hours. And we're anticipating launching that program on July the 1st. We are hopeful that many of the members that may no longer be eligible under this program will have interest and want to talk to us about transitioning to that pathway to coverage as well. They may not all do it, but I think because of members coming in and members coming out, I think our actual budget and our Medicaid membership numbers will be a little bit dynamic over the course of the next year.
may I ask one other question, Madam?
Sure, go right ahead.
Okay, on this, the study regarding the reimbursement rates for mental health care providers, can you share that with us?
Absolutely. So it is completed. We have transmitted it to the chairs of the Behavioral Health and Reform and Innovation Commission, as well as House and Senate leadership and the governor's office. But we'd be happy. It's actually public on our website at this point, I believe. But we'd be happy to get you a copy.
Thank you.
Thank you. Chairman Stevens, you have a question?
I do. It looks like the tobacco settlement money drops away this year, $124 million.
We're starting to get there. I believe that's correct, sir.
Thank you.
That was it? Okay. Representative Buckner?
Thank you, Madam Chair. To follow up on the pathways, when you were talking about the work requirement, I know in Peach Care there is a requirement for a premium to be paid based on family size and income. I'm curious why the pathways, if there was any conversation or thought about doing pathways the same way, so there wouldn't have to be a job or a volunteer service police of sorts.
Our waiver, as approved, is based on the qualifying activity. So it's not just work, it's a number of things. Being enrolled in school can count, job training, all of those things. So it's not technically a work requirement, it's a qualifying activity. You are correct. Those premium and copays have been suspended during the public health emergency. There is some component to that under the pathways in later phases. I think that's something that we could potentially consider, but it would not replace the qualifying activity. And Peach Care is a little bit different because the income thresholds on Peach Care, our CHIP program, are much different than the straight Medicaid population.
Chairman Newton, any question?
So I appreciate on the, some of the people getting recertified obviously won't be recertified and eligible, or not currently eligible, but they're just held as
Right.
eligible. I know one of the ways people get eligible is the federal poverty level multiplier changes if you become pregnant and have a child. It goes up to 250% of the poverty level, and you're eligible for Georgia Medicaid. Is that correct?
I'd have to double check that exact. It's very the limits are very different based on family size, number in the household, and different category of eligibility. But it does change.
So my understanding, though, is if somebody was making 200% of the poverty level, they had a child 2 or 3 years ago during the public health emergency, they have not been terminated off Medicaid as of yet, even though they make far more than the poverty level.
That's correct.
Is our program set up to get them enrolled in their equivalent of through the Navigator system or the
So that will be part of that
Healthcare.gov
redetermination. Yeah, so when it's their turn to be redetermined eligible, the staff, that caseworkers, will walk them through all possible eligibility coverage options, including a warm transfer over to the state exchange or the Navigator if that's where we need to send them.
And can't some of those be almost zero premium if they're in the lower income?
Some of them can be.
Okay, thank you.
Representative Buckner?
I couldn't find this a minute ago, but I know there's an increase for the state health benefit plan for the contribution per member for certified and non-certified school employees. It goes up to $1,580. What is it now? What is it going?
It's $945 per member per month. That's what the employer pays for each member that chooses state health benefit coverage.
And so it would go up to the $1,580 per member per month.
Correct.
Okay, thank you.
Number 23?
That was an excellent question. So if someone is participant per member per month, there's the employee, and then there's also potentially the employee's spouse or dependent children. Is the 945, would that typically have been 2 of those per month for a covered member and the spouse, or is that, because that's going from 18 or 1900 to 3,000 and something is
No, it's per member it's per the employee.
per employee?
Per employee, and then the employee.
It's not per covered life.
It's not per covered life.
Okay,
Someone
thank
correct me
you.
if I'm wrong. But just like for an active state employee, the state, my employer, is covering a portion of my salary, and then I choose the coverage for me and my family. But that amount is static.
Thank you.
But then I pay more.
Thank you. I have a couple questions, and it does have to do with your employees. I'm curious as to how many employees you have. We've heard from so many people the problems they're having with staffing, and I'm curious about how your staffing is, and we have a big project coming up, and your turnover rate. How are you doing?
So we've got 608 full-time equivalent employees right now. In years prior, we've probably been sitting closer to 800. We have 167 actual vacancies that range across our departments. Our healthcare facilities regulation department is probably where we have the most vacancies and the most turnover, and where we've had to rely on contract entities to help us fill that work. These are our generally nurses and others that are what we call SMQT certified. They're certified to go out and survey and inspect a nursing home. Or other skilled nursing facility or hospital. We do a lot of that work on behalf of the federal government, on CMS. We are their contract entity to do that inspection work as well. It's a very high level of qualification and certification for folks that generally could make more if they were in a clinical setting practicing. So we have done some innovative things over the past year. That number's probably down a little bit, but that's still where we struggle a lot. And then I would just add, from my experience as a budget and finance background, state is in short supply of budget and finance professionals that are willing to and ready to work within really the intense nature of what Medicaid would require, and in all state agencies, in honesty. But we're moving in the right direction. Our turnover rate this year is 10%. As I said earlier, eternally grateful for the COLAs that we've seen over the past couple years and for the one that's proposed this year. In addition, I would have to say, thank you to your leadership and support, we're moving out of our building into a new building this spring, which really is one of the best job recruitment and retention things that the Department of Community Health has going for us. To leave 2 Peachtree and move over to the Twin Towers, our team is very excited about, and we're going to use that as a recruitment tool as well. So thank you for your support of those funds.
Thank you. And that will help. That was one of our concerns, if you'll have staffing to take on what you've got ahead of you. One other quick question. Do you have any fees that are covered through operations and things that you do that the department does that aren't really appropriated by us? I don't know if your agency collects fees.
The Board of Dentistry and Pharmacy, and I've got them there at the bottom of slide 3 for you, they collect fees that are retained. I don't know that they use them, and it's a very small amount. All the fees collected by the Department of Community Health proper are remitted to Treasury. I think the biggest pot that you could argue that's probably not remitted to Treasury, but it's because they're in separate statutory accounts, is the SHPP premiums and revenues. If you, in the true sense of the word, define those as a fee, those go straight into trust fund accounts for either OPEB or to pay health claims expenses. Those are somewhat reflected in the budget through revenues.
Okay. Thank you. Chairman Hawkins?
Yeah, I'll speak to the dental thing. That's not what I was going to talk about. The dental, we actually increased, doubled fees, bifurcated them, took half with us to DCH and left half in the general budget. That's how we did it years and years ago to try to keep everything whole, and it was at a tough time, you know. My question is, are you moving your whole operation to DCH? Correct, was 18th, 19th floor or something? Is that right?
We have a number of floors at 2 Peachtree. We are cutting our square footage in half and moving over into the Twin Towers, and we'll be on 5 floors over there.
So you've got 5 floors, okay. So you've got some people working from home, right, like the other agencies?
Correct.
Okay, thanks.
Thank you. Are there any other questions? I see none, and we appreciate
you.
you. Thank you for your presentation. Next, we'll be hearing from the Georgia Board of Healthcare Workforce.
Good afternoon, and thank you for having me. Just give me a moment here to get the slide up. All right, good afternoon. I'm Chet Basine with the Georgia Board of Healthcare Workforce, and I'm thankful you want to hear from us today. Just going to open up and give a brief overview of who we are. Again, just due to new members, we're administratively attached to DCH. We are the board that administers loan repayments towards physicians, dentists, nurse practitioners, and physician assistants that practice in rural areas, which is defined as 50,000 or less in the county population. We administer operating grants to Morehouse and Mercer Schools of Medicine and issue a series of other grants for starting up residency programs, nursing, school scholarships, and so on at a high level. Our board is 15 individuals, predominantly physicians. We do have 1 dentist, 1 nurse practitioner, 1 physician assistant, and 1 person who is not affiliated with the business of healthcare whatsoever. So that is our board in a nutshell. We do not collect any fees formally, so there's none of that. And from a turnover perspective, we are a small team. We are currently a team of 8. We have 1 vacancy. The individual who is slotted for that, I'm told, is set to begin per his background check on March 1st. So from a budgetary perspective, the governor's recommendations, you'll see in section 17.11 from the board administration. These are the first item, 17.11.1, is the statewide cost of living adjustment that we also are very grateful for. It'll help with retention from our staff. And then the second line item is 17.11.2. This is $180,000 for additional staff and/or technology. This, as I get into the loan repayment program expansion that's further on in this presentation, these monies, this $180,000, will assist as our workload increases and we're allowed to serve more Georgians. In section 17.12 is graduate medical education. Graduate medical education is also known as medical residence, if that helps out. We also have the FMAP adjustment. Again, just like Commissioner Noggle just mentioned a moment ago, a small change in the federal amount equals a swing in our amount, so that the net delta on that, even with about a 13 basis point reduction, yields it's $186,774 is the increase we need to offset that reduction. Line item 17.12.2 is funding for an additional 102 medical residency slots, primarily in primary care. That's $1,772,192. And finally, final item in this section is 17.12.3. It's $375, and that is to fund feasibility studies for graduate medical education. So that would allow hospitals that are interested in either increasing or getting into the GME business, they would have the ability to apply to a grant to then study the capability if they do have the infrastructure and the factors needed for success. I'm going to move on to section 17.13. This is the operating grant that we administer for the Mercer School of Medicine. The only change in here, the recommendation is 17.13.1, which is for $663,114. This is to support their long-term endeavor of opening up their Columbus, Georgia campus. I believe that campus currently has about 117 enrolled students, and as it continues to mature, that enrollment will increase. So that is that section. And then the next section, there are no recommendations listed. That was the 17.14, so I'll skip over that. Here in 17.15, this is physicians for rural areas. The first section is a 17.15.1. It's provide funds to establish a loan repayment program for mental health professionals. This is a program that will allow us to administer a program not just at the physician level, but psychologists, counselors, therapists, social workers, all those who are very important in the behavioral health continuum, to establish a loan repayment program to continue to attract behavioral health practitioners here to the state of Georgia and perhaps even to stay. The next section is 17.15.2. This is we will administer a loan repayment program, but this is for the GBI, Georgia Bureau of Investigation. They have a number of vacancies they're looking to fulfill, and these monies will be allocated just for their recruitment efforts in order to increase their forensic pathologist count. 17.15.3 is the physician loan repayment program. We already operate this program, but these funds are here for us to expand the program. That's also the way the program is currently. A physician applies, he or she would, if they are selected, they get the award for a year. They can apply for 3 more years. This would allow us to make a commitment to the physician in the same communities that we currently have earmarked, but we can make a financial commitment to them for multiple years, hopefully making it more attractive for them to go to these communities with 50,000 or less. And then lastly, in this section, we have 17.15.4, $440,000, and this is just to allow for additional dollars for the physician assistant and nurse practitioner loan repayment program. We have found over time and time again, we have more applicants than we do have funds. In fact, this past year on the nurse practitioner side, we had, can't recall the exact amount, but it was quite a lengthy list. So this would allow us to administer more of those repayments to those individuals and work in those communities. The next section is 17.16. This is undergraduate medical education, also known as medical school. In here is funds to establish a nursing faculty loan repayment program. So for this would be $1,050,000. These monies, again, would be there for nurses who want to, say, teach, precept, help train the nurses of tomorrow. Right now, at a high level, we all know there's a nursing we're low on supply of nurses. There are some nurses that would like to teach, but what we hear is they can make more money in a clinical setting, so perhaps a loan repayment program would incentivize some nurses to help train some more nurses of tomorrow, thus increasing our supply in the long term. So that's the money behind that. And then in summary, the final slide shows our budget numbers. We go from $104,994,033 with the governor's recommendations of $7,767,429, ending up with $112,762,63. So with that, I'd be glad to take any questions.
I don't see any question. Well, there we go. Thank you. Chairman
Sorry.
Newton?
If you don't mind, thank you, Madam Chair. On your summary, the graduate medical education, I know you show it going up $2.3 million to 32. Is that total, does that a lot of, have we been increasing in the number of residencies? I've heard more and more of our, even rural hospitals are adding 1, 2, 3 residency programs. Is that something we're supporting? And how, I know there's a startup that you have to cover locally or in the state, and then at some point GME or Medicare can pick it. Can you explain a little bit of that?
Yeah, absolutely. That's a great question. So the answer is yes. For the programs that make us aware that they're entering the GME or the graduate medical education space, those are the ones that, if monies are appropriated, we do enter in a contract and administer funds. There are a number of smaller hospitals, not the large names, the Emorys and the Grady's of the world, that are bringing in cohorts of, say, 4 family practice physicians per year. It's a 3-year residency, so they'll have 12 in totality. That is common. I'm hearing that there are other facilities or hospitals looking at that. With the grant that's in here, I know I'm switching to a different line item that might motivate one from what's in 1712.3, that might motivate somebody to start looking at this line of business, if that makes sense.
If I might, and some of those, my understanding was that there's like skin in the game for the local either hospital or the state, but at some point, if depending on certain characteristics, the feds might take over the funding of that. So could some of this just be 1, 2, or 3 year money, and then we can shift it over to a different?
Yeah, yes, in the sense that when we provide the funding towards the GME sites, the state is providing funds. There is a federal matching component, which I believe is what you're referring to. The totality of that then amounts to a much larger amount than what the state appropriates, and that allows the residency programs to operate. But from a skin in the game perspective, I am, right now, nothing is coming to mind where there's a potential reduction in reimbursement or funds being made available to them. As long as they stay compliant through, generally it's the American College of Graduate Medical Education, ACGME, is the standard around the country where all residency programs get accredited through. That's the big thing for them.
Thank you for your work.
Sure.
Representative Sewell, you have a question?
Yeah, thank you. So for all these loan repayment programs, these folks are staying in Georgia. They're contracted to practice for so many years in Georgia if we pay for their schooling.
Let me make sure I understand. You're talking about the loan repayment program specifically?
Yes.
The loan repayments is currently set up on an annual basis. So if the physician, dentist, PA, or AP, or a nurse practitioner stay in the area, provide the care for that 1-year term the way they're set up right now, and then they decide to leave that county and come to Buckhead, for example, they've fulfilled their term. Now, we could adjust that to perhaps retain them, but the way it's been administered for this point, once they fulfill that 1-year term, they have fulfilled the obligation of the contract.
Okay, so they're obligated to stay in Georgia for 1 year?
They're obligated to stay in that county that they've applied from.
Okay, but if they leave and go to Alabama, they're done. They've done their job. Okay.
Yes.
Thank you.
Chairman Hawkins, did you have a question?
I believe.
Okay. Thank you. You have no other questions.
All right.
Appreciate it.
Thank you for your time.
Our next presenter will be the Georgia Department of Public Health. Welcome, Dr. Toomey. We're happy to see you.
Oh, good afternoon, Madam Chair and the rest of the committee. Nice to be here. Thank you so much. I'll be sitting here at the table because it's just more comfortable for me to
That's fine.
sit here. And my CFO, Will Bell, will be sitting next to me.
Pull the mic a little closer.
Oh, sure, certainly. Thank you.
Thank you.
I know many of my colleagues launched into the questions that we kind of auxiliary questions that we got, but I'd rather start with the budget first and then do that if that's all right with you.
That's fine.
Looking at the governor's recommendations, we too have the same statewide changes that the other departments have. Just a reminder that we have 4,000 staff that work in county health departments. They're not state employees, but they're Board of Health employees. They also are receiving these increases, and so that's a plus in terms of retention and recruitment, as well as the 1,000 state staff that we have. So approximately 88% of all these additional, particularly the cost of living adjustments, are going to county health departments. I think it's important to note that. Next slide. I just wanted to highlight one of the reductions that you may remember last year. We got a $350,000 increase for some ambulance equipment and repair for McIntosh County. We worked with the county. We were able to get that equipment and that fire safety in Heard County, Heard Island. And with that completed, we expected this to be cut because it's no longer needed. It's been completed. So that is the one reduction. And then the final and very important point I wanted to talk about is the increase in the PrEP program. And I thought it was probably worthwhile to explain again what PrEP is, because I realize you have PrEPs before you have surgery and you have PrEPs before dental procedures, and it could be a little confusing. PrEP, in this case, is the pre-exposure prophylaxis to protect against acquisition of HIV. So it's, in a sense, it's a preventive measure to stop HIV transmission, particularly for those at high risk, men or women at high risk for acquiring HIV. And with your generosity, we had a pilot in several counties, both in the Gainesville district and also in the Rome area. But those, because of the COVID pandemic, and a lot of the staff that were working on it were redeployed to COVID, and we did not get as much developed as we did. And we have requested some additional, or the governor has seen fit to give us some additional funding, particularly for those areas that don't have PrEP programs now. In the metro area, there's fairly extensive PrEP programs, but many of the particularly rural Georgia do not have them. And this will be the funding to begin to ensure that there's statewide coverage for this pre-exposure prophylaxis to prevent HIV transmission. And remember, this coupled with treatment for those already HIV infected will be the combination of ingredients that allows us to stop the spread of HIV here in Georgia. We have in the South in general, and in Georgia as part of the South, some of the highest rates of transmission. And we see this as an extremely important measure that we can do to stop the spread of HIV. And so we're very grateful to the governor to including this in the budget this year. And the last additional item is a general obligation bond, and this is for maintenance and repairs in the public health laboratories, both here in Claremont and the DeKalb County, as well as down in Waycross. And you may recall that we have a sizable federal grant, which we got from the Centers for Disease Control and Prevention, over $28 million to do significant repairs and upgrades of the testing capacity within that laboratory. But those federal funds do not pay for everything. They don't pay for furniture. They don't pay for the new carpeting that's needed, particularly after our the pipes burst over Christmas, and we have a lot of kind of cleanup to do. And so this will basically work in coupled with the federal dollars, almost as a small match to those federal dollars, to allow us to complete those renovations of the laboratories, and that's $975,000. And that completes the items in the governor's budget. But I'll be happy to answer the additional questions that we were.
I do have one, and it had
Sure.
to do with your capital needs. That's
Sure.
one of the things I was concerned about, and it did reflect that. Do you have any other capital needs that aren't being met? Is the department able to meet the needs right now for capital expenditures?
None that I am aware of. Remember, we do not maintain county health departments, just the district offices and obviously we too are moving here
Yes.
away out of to Peachtree, which we are jubilant about.
When are you scheduled?
Probably around May and June, and we too will be reducing the footprint by about half, and so some of our staff will be working in the office part of the time, some teleworking part of the time. But if you haven't come to visit me at 2 Peachtree, you'll understand why we're very excited about the move.
Another question has to do similar. You have so many professionals that work with you, and I am concerned about your head count of employees, and if you're able to fill the needs, how many you currently have, and are you able to fill those positions? So many people have told us that is their number one problem, is getting staffing.
Workforce, particularly the technical staff, both in nursing, epidemiology, and even environmental health specialists have been very difficult. But the increases we got last year, both from the governor, but also additionally from your leadership, we have actually seen a decrease in turnover within
Great.
those positions. And actually a decrease even in the turnover in the county departments as well. So for us, it's a good news story. We are still, obviously, particularly nursing is in short supply, but we are having.
Do you have vacancies right now that you need to fill?
We have right now about 140
Okay.
DPH, so that's state vacancies, and about an estimated 310 vacancies in the county health departments. And so again, those aren't state employees, but they work in conjunction, or they're part of the extended team. So, but out of 1,000 employees, about 140 vacancies currently.
Okay, because that is, again, that's an issue that we're seeing
No,
everywhere.
absolutely.
Our meetings that I've had, that's the number one issue I seem to hear, is not having enough technical skilled, trained nurses, doctors, everything, so.
And
Thank
I am pleased that I can tell you that the budget increases have made a measurable difference in our ability to retain people. And
Thank you.
over the years.
Let's see. Do you have any fees that are covered, that you aren't in the budget? Y'all aren't really in a collection mode.
No, the counties have fees, and we can talk about that at some
But
point.
do they keep those fees? For example, I guess they could go there for a test, and I know COVID, they were not charging for testing. They just provided that
right.
service. I don't know that there are any fees.
Well, the one fees that we charge at the state level, and I'm almost hesitant to talk about them, because I know for those of you in rural Georgia, this is a difficult subject. It's septic tank inspections and the septic. We have the authority for sewage management
Right.
inspections, and so that is the only program that we charge fees for within the state office. Those funds, with OPB's support, roll back into the program, and that's what pays for the staff that actually do those inspections. And those fees are collected every other year. And so we have to carry them over. That's why OPB helps us with that. But that is the only collection within the state office.
Thank you. Any questions from the committee? You have none. Thank you very much. We appreciate your service and how hard it has been for you over the last couple of years, so thank you.
Oh, thank you so much. You have no idea how much we all appreciate your support.
There's light at the end of the tunnel. Thank you.
We're already seeing it, so
Thank
thank you so much.
Thank you. All right. Our next presenter will be the Office of Health Strategy and Coordination. If you would introduce yourself and tell us a little bit about your organization.
Absolutely. Thank you, and good afternoon, Chairwoman Taylor and members of the House Appropriations Health Subcommittee. With me today, I have Elizabeth Holcomb, who is our Deputy Director and Legal Counsel. She'll be moving us through the slides through the presentation. But as Chairwoman Taylor already stated, my name is Grant Thomas. I serve as Director of the Office of Health Strategy and Coordination. We are an office that operates within the Office of the Governor, and we are administratively attached to the Governor's Office of Planning and Budget. I greatly appreciate the opportunity to be here with you all today to talk about OHSC and our priorities and projects that we've undertaken in the state fiscal years 2022 and 2023 budget cycles, and to speak on the ongoing work of the all-payer claims database that relates to the recommendation in the governor's budget for OHSC in FY 2024. One of the things that Chairwoman Taylor asked me to do, since we are a relatively new office within state government, I wanted to just provide a brief history of OHSC and our priorities before presenting several health initiatives that we've been responsible for in both FY 2022 and FY 23. We were established through House Bill 186 during the 2019 legislative session to strengthen and support the healthcare infrastructure of the state through interconnecting health functions and sharing resources across multiple state agencies and overcoming barriers to the coordination of healthcare. You may recall that was House Bill 186 in the 2019 legislative session. There were a lot of different healthcare initiatives that made their way into that bill by the end of the session, and the creation of our office was one of those. One of our primary charges is to help ensure that the healthcare issues of greatest importance to the governor and the state are identified, and that appropriate stakeholders are brought together, both internal with our state agency partners and external stakeholders as well, to work on and address those healthcare policy issues, and but also operational issues, the provision of healthcare services, just ensuring that all entities are working together for the betterment of healthcare in Georgia. The powers and duties of the office, as I've stated before, include facilitating collaboration and coordination between state agencies, coordinating state health functions and programs, and serving as a forum for identifying Georgia's specific healthcare issues of greatest concern. In 2022, House Bill 1013 also assigned our office with additional responsibilities that include overseeing the coordination of mental health policy and behavioral health services across state agencies. And our office also advises the governor on healthcare policy issues. Governor Kemp appointed me to the position of Director of OHSC in summer of 2021. That was following the office being funded for the first time in the FY 2022 budget during the 21 session. Just want to note before I get into more specifics that our ability to be effective and work on these issues really relies on the partnerships that we've built with with our state agency partners, as well as different stakeholder groups across the state who have brought issues to us. Specifically, want to call out DCH, DHS, DBHDD, and DPH, who have been great partners, as well as Board of Healthcare Workforce, Composite Medical Board, and others. And we've also worked closely with Commissioner John King in his office to implement the reinsurance program from the Governor's Georgia Access Waiver, as well as now moving forward with a state-based exchange. Their office is overseeing implementation and operations of both of those components of the Georgia Access Waiver. So we've been very involved working with them on those initiatives. If you go to the next slide, this slide outlines, and you should have it in front of you, different health initiatives in FY22 and FY23 undertaken by the office, and these are different projects that I'll touch on today and go into further detail. The first one is the implementation of the all-payer claims database. This is one project that was assigned to us in statute through Senate Bill 482 during the 2020 legislative session. Review of the Medicaid managed care contracts and providing recommendations to DCH ahead of upcoming procurement cycles. This is a responsibility that was outlined in our initial statute. We were also in House Bill 1013, as I mentioned earlier, assigned those additional responsibilities, but specifically we undertook a survey and study on the transport of individuals to and from emergency receiving, evaluation, and treatment facilities, ERETs for short. We also were charged with recommending and creating a comprehensive unified drug list, both for mental health and substance use disorder prescriptions in both the Medicaid and Peach Care programs, as well as state health benefit plan. That was another directive in House Bill 1013. And then last year during the budget process, our office was assigned additional funding, or appropriated additional funding by you all to collect and report on nursing and hospital data and really take that data and information that the state's already collecting through different surveys and mechanisms and reporting that data in aggregate form. And we've partnered with the Georgia Data Analytics Center at OPB on those projects. So the next slide gets into the APCD. That's just a summary in statute of the directive from Senate Bill 482 that I mentioned for the Office of Health Strategy and Coordination to oversee and manage implementation of the all-payer claims database. Next slide, I'll go into more detail about what is an APCD. So an all-payer claims database is a centralized data repository of healthcare, pharmacy, and dental claims data collected from both public and private payer sources across the state. Essentially, the APCD will seek to promote price, cost, and quality transparency, assess geographic variations in price and utilization, track healthcare spending drivers and trends, and promote public health. There will really be an increased level of transparency that will allow healthcare purchasers and consumers to identify and compare healthcare prices and utilization information across different healthcare facilities and providers. And the public will be able to see different health plans and insurers, what they have paid for providers of specific healthcare services. A lot of this information is held privately right now, and it's through private contracts. What one insurance health payer on a commercial plan is paying to a healthcare facility, and through this claims information that the APCD will be collecting will really get insight and information into what different payers are paying at different facilities and how that differs across the state, and be able to utilize that information for a lot of important use cases. So I'll go to the next slide. The Georgia APCD team, there are multiple entities we work with on this project. As I mentioned, we are charged in statute as the entity that oversees the budgetary, has budgetary oversight over the project, and also is charged with implementing. We also work with the Georgia Tech Research Institute, Center for Health Analytics and Informatics, GTRI for short. They're assigned as the administrator in Senate Bill 482, so they'll really be working to help get new payers into the APCD. They'll help us with the priority use cases that we have for the projects, and really bring their analytics expertise to help develop those use cases. The Georgia Technology Authority Empowerment Fund provides project assurance. As I mentioned before, Georgia Data Analytics Center, they are responsible for hosting that analytics environment. And then OnPoint Health Data is our data collection partner and software supplier that helps us build the environment that will ingest this data and helps payers onboard that claims information. So entities required to submit to the APCD, this is something that we get asked about a lot. In statute, there's a requirement that commercial health plans of at least 1,000 covered lives submit data to the APCD. So this includes, your private plans on the individual market, large small group plans, Medicaid and the state health benefit plan will also be submitting. And then RISA plans, while not required to submit, we're hoping that a lot do voluntarily, and we're working a lot with the payers to help collaborate, coordinate on this effort with them so that they can give input, throughout the process, and really work with them to, show the benefits of, submitting data. And a lot of them already have opt-in clauses that allow for the data to be submitted. So now I'll get into the prioritized use cases for the APCD. There's really no shortage of ways to use this data. In the initial phase of analytics, our team identified 12 priority use cases through the APCD Advisory Committee that exists in statute that Chairwoman Taylor is now a member of, and they're fall into 3 different categories. Those are cost and utilization, population health, and healthcare quality. This is by no means an exhaustive list, but these, are the prioritized use cases initially. There will be many more use cases in the months and years to come. So going to the next slide, I wanted to give everyone a specific example of a use case of how this data can be used. And one of the use cases on the previous slide was avoidable costs. So the slide that is up now demonstrates how the state of Virginia was able to leverage its APCD to identify an opportunity to improve healthcare utilization and the quality and financial impact. Using its APCD, Virginia identified that roughly 14% of the 1.5 million emergency department visits within the state in 2017 may have been avoidable if they had been redirected to the primary care setting or a primary care provider's office. And this could have led to a savings of potentially $100 million that could be achieved through initiatives of redirecting those residents to make better decisions around healthcare utilization and direct them to those providers when a emergency department setting is not appropriate, because as we know, the emergency rooms can be one of the most expensive places to receive healthcare services. So where we are right now on implementation, the following slide shows implementation dates. Target dates that we have hit and ones that are upcoming for implementation. Our data collection vendor was awarded in October of 2022 last year. The data submission guide, which explains to payers how they can submit data to the APCD, or how they are to do that and what fields that they should submit, went out in December. The APCD portal that will start ingesting the data will be available in April 2023 for payers to begin submitting. Mandatory submission for the last several years of data for payers will be June 1st. And then mandatory submission of dental claims will be December 1st of this year. We are intending to have initial analytic use cases, so like the example I just showed, starting to get into those different use cases that we can report out on and start utilizing the data by January. And then finally, we should have all payers onboarded, including additional payers beyond the ones I just mentioned, Department of Corrections data, Cannabis Commission, and others that are outlined in statute that would also have to submit data by the end of 2024, which is sooner than we anticipated. So next slide shows the APCD budget and state funding allocated to the project. And this can also be seen on the tracking sheet on page 5 under 27.5. You'll see on 27.5.2, we are proposing, the governor's budget proposes to transfer funds from DCH over to Office of Health Strategy and Coordination. This is the $800,000 in base funding. As Commissioner Noggle mentioned earlier, we were established in statute, but we're not operational at the time funding was first appropriated for this project. So they have been holding the funds, and we've worked on administering those through an MOU with DCH. But this change just transfers that funding over to OHSC, given that we are our own program in the state budget right now. And then overall, the budget consists of $800,000 in base funding to DCH, and then we were also last year you all appropriated $2.8 million in the amended FY22 budget for the project, and then we also received the allocation of $800,000 in FY23, and then an additional $1.2 million was allocated to the GTA Empowerment Fund. So we have been working through that process on administration of the APCD, and they've been great partners in helping us to implement. We're also able to draw down federal funds for the project through a 90-10 match partnership, given the impact that the APCD will have on Medicaid funding. So because having an APCD and developing these use cases will give the state better insight on into the state's Medicaid program and how we're spending our Medicaid funds. There's a significant benefit to Medicaid, so the federal government is helping with implementation costs. And then once the APCD is operational, they will continue to provide funding for maintenance and operations, likely at a lower rate, but still provide ongoing funding. So moving on to the next slide, getting into some of our other initiatives. As I mentioned at the beginning, we conducted a review of the current Medicaid managed care contracts and the state plan ahead of the upcoming procurement cycle, as is directed in our statute. And we provided that recommendations report to DCH in October of 2022. That is accessible on our website, and the report really looked at national trends with Medicaid managed care, what other states are doing in their Medicaid programs, and then also developed specific recommendations in different categories around the managed care contracts, specifically looking at how we can reduce administrative burdens, improving care coordination, providing more prescriptive requirements for care coordination in the state plan, and then also different health equity initiatives, as well as initiatives that will address social determinants of health. So happy to share that report with any of you. Moving on to the next initiative, the emergency transport study, as directed to us in House Bill 1013. We conducted a study that looked at all emergency transport over a 6-week period. We partnered with the Carl Vinson Institute of Government at UGA to do that study. This was emergency transport for individuals in mental health crisis has been a major concern. It's definitely as well put a burden on different law enforcement professionals who sometimes in rural areas of the state have to transport individuals, through very long distances to get to a healthcare facility, and I think the legislature wanted to better quantify that and see, okay, where are these individuals being transported to and from? What counties are they coming from? What is the frequency? What is the cost of this? And so we were able to look at all of those different factors and look at the different transportation methods and the frequency by which individuals traveled by ambulance or law enforcement professional, families and friends. And what we found was that ambulances were by far the most common mode of transport and also the most expensive. And then on the admission side, and then family and friends being the most common mode of transport for discharge transportation. In addition to the basic survey that was that required by statute, we also looked at other states across the southeast in the country of what they had done to address this issue, to see how they were addressing transport for individuals, in mental health crisis. We specifically looked at Tennessee and Virginia, who have grant programs specifically to deal with emergency transport. Tennessee provides a grant program that counties can utilize up to a set amount to provide funds to help subsidize some of the costs for local law enforcement in doing this. And then Virginia actually has a statewide contract with a non-emergency medical transport provider, so they're able to provide assistance to local law enforcement and counties with those transportation obligations. And then we also looked at the state's bed coordination efforts, to see how GCAL was being utilized, and the frequency by which sheriffs and law enforcement contacted GCAL for recommendations on transport, and made recommendations in that area as well. The next initiative, this was another directive in House Bill 1013, was a preferred drug list study. So the legislation directed us to recommend one preferred drug list within Medicaid. We have 4 different drug lists in Medicaid right now, one on fee-for-service, and then each of the care management organizations, CMOs, also has their own drug list. So we've got a total of 4 on Medicaid, and that we were instructed to, for the categories of prescriptions that classify as mental health and substance use prescriptions, to take those and make a recommendation for a unified drug list across Medicaid. And then we did the same thing for the state health benefit plan. We've got 3 plans on SHBP. 2 of them use the same pharmacy vendor, and then one is separate. Kaiser is a separate plan that has an integrated model. So there are 2 separate lists on the state health benefit plan side. So we did that, the same exercise on that side as well. We contracted with Mercer, which is a national actuary, to do this study, and looked at numerous factors, including budget and operational considerations, comparisons of current drug lists and that are used across programs, and a review of state experiences with unified drug lists in other states. One of the, in the report, we list several advantages and as well as considerations when states move to unified drug lists. Some of the advantages are moving drug utilization to the lowest net cost, higher rebate negotiating leverage for the state, as well as consistent expectations for beneficiaries and providers when they know that Medicaid has when there's one list in Medicaid as well as one list in SHBP. There's also other considerations that the state would need to take into account when considering making this transition that are outlined in the report. Just one limitation I wanted to note on this study: we were not able to access the rebate information that would inform the true financial impact of this. There are federal rebates that the state collects, and the CMOs do not have insight into that rebate information. So, without the rebate information, recommending if a drug is generic or the brand name, without knowing that cost information and the rebates, we couldn't fully complete the recommendation, but we did include different steps in the report that the department could take if it was to move forward with finishing the study and gaining insight into that true financial impact. Just to recap, all the reports I've mentioned are available on our website, but happy to share any of those with you all. Going into some funding that was appropriated to us last year in the FY23 budget, there was a line item related for $126,000 approximately to assist us with collecting and reporting on nursing and hospital data. This relates to legislation that was passed in 2019 with House Bill 186 and 321 that increased hospital reporting requirements for individual hospital and financial operational information. And DCH currently collects this information through their annual surveys and the hospital financial survey, but no one was taking this data and aggregating it and really putting it into one unified format where you could easily compare the financial information across hospitals. So we, like I said earlier, we were able to partner with the Georgia Data Analytics Center on taking this data and presenting it in a transparent format, an aggregate format that the public and other stakeholders can easily access and gain insight into. And that dashboard went live late last year. We can actually show you just a screenshot of that. It's in the slideshow as well. But that gives you a glimpse of what that dashboard looks like. Like I said, it's live now, so happy to share that link with you all. Next slide. So just looking forward to future data sharing opportunities, OHSC in partnership with the Behavioral Health Commission has evaluated data sharing issues across state government and looked to other states for their for insight into how they've dealt with data sharing and seeking ways to make that a more efficient process. Because we all know data plays such an important role in enhancing the delivery of services and improving overall efficiencies across government. And it can further be improved by establishing a unified framework for statewide and interagency data sharing. There are opportunities that exist to standardize this process and enhance interagency data sharing. Other states have also created presumptions of data sharing between states to really underscore the importance of agencies working together to do this. We've worked closely with the Behavioral Health Commission studying this issue and on development of recommendations. Those can be found in the BHRIC's 2022 annual report that outlines best practices for data sharing and what some other states have done. And grateful to many of you for your partnership on those efforts. And before I wrap up, I just wanted to give some additional insight into some other data initiatives underway, specifically with GDAC. They've also undertaken non-public facing dashboards and data projects. One example of this was interest in the hoteling issue and helping the state better understand and track data relating to the hoteling of foster care youth. And this internal work has allowed us to gain better insight and to see where across the state hoteling is occurring at a higher frequency, and look at other contributing factors that may be going into that to help try to reduce and ultimately eliminate the practice of hoteling. So in the short time of being operational, GDAC's work to innovate and use data and drive and inform policy decisions, their partnership with us and other agencies is truly impressive, and it's exciting to see some of this data sharing open up and to be able to gain better insight so that we can make better decisions around healthcare issues, specifically healthcare workforce. And other, provision of services issues across the state. So with that, thank you, Chairwoman Taylor and the committee for the opportunity to talk to you all today more about and to share more about OHSC and our work. Happy to take any questions that you all have.
You do have a couple questions.
Okay.
And I do appreciate this presentation, and it's a major endeavor that y'all are trying to get everything together. It really is fascinating when you look at some of these numbers, so we appreciate your efforts. And your first question is coming from Chairman Stevens.
Thank you, Madam Chairman. And thank you for pulling the data together to give us a really good idea to get a standard list for drugs, for example. I guess my question comes down, how in the world do you give us a standard list whenever you can't access the real rebates that pharmaceutical? I mean, if you're measuring apples to apples, don't you need to know the cost?
In order for it to be a full and complete study, you do need access to that rebate information, as you said, which DCH does have that, so they would be able to take the information that we've provided and complete that study. But given as you mentioned, the rebate information and the discounts that it can provide to brand name drugs, without full insight into that, those recommendations cannot be final. We were able to look at those the clinical aspects of some of those those drugs that are on those lists, as well as conduct a member disruption study to see A lot of these drugs are already unified across the different Medicaid plans and SHBP. I believe in SHBP it's about 88% unified already. And then in Medicaid, it's about 63%. And a lot of those times, 2 or 3 plans are covering the same drug, and there may be one outlier, one plan or the fee-for-service side that it is not aligned. So we were able to look at other factors such as, the clinical aspects and what it would mean for member disruption. But to your point, in order for that to be a full and final recommended report, you do need to gain access to the rebate information and factor that in to look at the financial and fiscal impact on the state.
Follow up?
Yes, go right ahead.
What about the 340B plan? Do you get access to those numbers?
Our office has not sought those out specifically, but the department may be able to answer that further. Yeah.
Thank you.
Thank you.
A further question? Representative Hughley?
Thank you, Madam Chair. You guys seem to have been very, very busy and had a lot of studies. Can you tell me, when you all looked at the CMO contract, what was the #1 recommendation that the state has done as a result of your work?
Yeah, so, one thing there I would say is, those, the contracts and the provision of the Medicaid managed care plans, lots of agencies are, impacted by that. You've got the Department of Human Services and DFACS that, manages and oversees the foster care population, as well as, DBHDD that, provides and oversees facilities and services on the, within their plans for behavioral health care services. So really ensuring that, it's kind of clear for the managed care entities, how they need to be working with other agencies, and in addition to DCH, but also working with those other agencies to help ensure that those services are delivered, because those agencies have a lot of expertise with those populations. So I think that's one component. There's a lot that can be done as well. Related to being very specific in the contracts about what the expectations the state has for the managed care companies, or those entities that are providing those services, related to care coordination, providing for specific tiers of care coordination, that based on someone's, medical background, or kind of how medically complex that individual is, what level of care coordination they need, being very prescriptive around that. We've also seen a lot of other states really try to address social determinants of health through closed loop referrals. So working with community-based organizations to help address gaps in transportation and lack of access to, food, working with food banks. So there's really a lot that can be done, and that is detailed in that report, regarding, just how to have specific contract requirements, and then making sure that the state enforces those and has good partnerships with the managed care entities to deliver those services.
Thank you, Madam Chair.
Chairman Newton, you have a question?
Thank you, Madam Chair, and thank you so much for your work. And about a year and a half with four full-time equivalents, this is a impressive amount of work. Do you have a budget for consulting too that you've gotten? So you have some additional
Yes.
resources you have available to you, because I'm looking at the scope of this and it's pretty dramatic. A couple of quick questions. I noticed the all-payer claims database on where you had the due dates for various things. Here on page 10, you've got like the mandatory submissions for health and pharmacy are all due in June of this year. When do you expect those to be available to the public, to this body, to other health committees, for one?
So there's a very deliberate, specific process to ensure that the claims data that is coming into this environment, it has to be kept secure, and once it comes in, it's de-identified and
Right.
kept secure, and we've have a lot of guardrails and to protect that data. But there will be a data review committee that will be set up that individuals and research organizations who want to access that information can submit those requests to the data review committee that will be comprised of individuals from our office, the Georgia Tech Research Institute, and vet those requests to ensure that any information that is released is there's no potential that it can be re-identified. Individual claims can be sought out that we protected health information. But I think that's all part of that process as they ingest that data, and we're able to start doing those analytic use cases with the data in the beginning of next year in January. We will be able to start vetting those requests and being able to provide that information.
If you don't mind, the follow-up question on number 4 is actually a follow-up to Chairman Stevens on page 14 about the preferred drug list, and in particular with the mental health drugs. You mentioned the cost and consistency and things like that. We've heard from many people about some of the newer medications that may be more expensive, but they're once a month, either injections or once a month treatments that may even though they might be more expensive from a pharmaceutical point of view, they might avoid unnecessary ER stays for schizophrenia, for major depression, possibly even for substance abuse with some newer medicines. Are you able to get the information you need when you look at, the cost is clearly better for a 3 times a day pill, but if they don't take it and end up in the emergency department with the transport to an emergency receiving facility in behavioral health, the entire budget's been impacted far different than just the pharmacy benefit side. Are you able to pull in the resources you need to look at the clinical differences, or do you need additional legislation either for the rebate information Chairman Stevens mentioned, or to be able to crunch those numbers to look at the total cost of an episode of care, for example, or a year of care, as opposed to, especially if they might be better on a long-acting medicine that's more expensive?
Yeah, so I think to answer your question, there are many different factors that have to be looked at when you're reconciling these lists and looking at the different lists in terms of member disruption. What are these individuals currently getting and have access to through a preferred drug list? So that's one component of it. The financial component is another big one, as you mentioned, with the gaining access to the rebate information is critical in order to fix this. But we were able to look, I think, as part of our study, the clinical aspects as well. To your point, and that was taken into consideration on those lists that were recommended, and those lists are in the report in our in the appendices that for both state health benefit plan and Medicaid.
Thank you.
And I would just add that the access issue for the rebate information was because of the confidential nature of that information, which is why we couldn't get it.
Yeah. So that data, to Elizabeth's point, is proprietary information that the department is not able to disclose further. There could be some potential alternatives that we've proposed to gaining access to that data, but I think the approach that's being taken so far is we provided these initial recommendations, and in order to finish that study, they have access to the rebate data, so they can finish that last part if they choose to.
Chairman Hawkins, you have a question?
In the 17 years I've been here, I've never seen an agency move so fast and get so much done. Congratulations. I'm really impressed, seriously. I do have some concern with preferred drug lists, and I think I sent you an email on this. And this just goes back to about 2008 when we, through the LIM, the DCH, Medicaid, started going to brand drugs over name drugs for, especially for the children and epileptics problems, and we saw an increase in seizures. And it came about from the isometric difference between a preferred name drug and a generic. And I'm sure that you folks are aware of this and will be on the lookout, because when we start talking about this, especially with mental health drugs, for the adults, it didn't seem to, those changes didn't seem to affect them as much. But for pediatric doses, we did see a big difference, and we had to backtrack a little bit on some of that. So,
thank you. Thank you for those comments. That's something the state will definitely need to take into consideration.
Thank you.
Thank you, and thank you for your comments. The support from you and your colleagues has been great in helping us to move forward with a lot of these initiatives.
Yeah.
Thank you for your presentation, and I will say I did have a meeting with him, and I too was very impressed with how much you have already gotten information together. I will add the 340Bs in particular. We sometimes have trouble with them being a Medicaid subscriber and then taking it to a pharmacy that doesn't take it. I think we need to use some direction there. And at this time, the department is looking at the CMO contracts, and I think that's going to be beneficial too. And I know your input will be valued with them. So thank you very much.
Thank
We
you.
appreciate you. Thank you. Okay, we have one more presenter, and that's the Georgia Trauma Commission. If you would come forward, thank you.
I know you saved the best for last, so,
Yes.
and I give you, as you all have schooled me well over my first 3 years in state government, a one-pager that Tara has provided you with. And I'm Liz Atkins, Executive Director for the Georgia Trauma Care Network Commission, and we're an office of 4 people, inclusive of myself, with the task of adjudicating the $23 million in funds that we receive. Our funding streams are primarily the super speeder is our largest revenue. And then we get a smaller portion of the fireworks excise tax. Thanks to, during the 2021 legislative session, House Bill 511 that passed that established the Georgia Trauma Trust Fund. So now the fees are actually dedicated to us. So we have been navigating some of the differences in how we receive our money and how everything's appropriated. So this is actually the first time I'm seeing you because we didn't have an amended. There's no longer a true up because the funds go directly to us. So with the one pager, we don't, our funding buckets really don't change from year to year. Primarily what you see, and I'll direct you kind of down to the bottom of the page because the bulk of the money is distributed between our EMS stakeholders and the trauma centers. So with the EMS stakeholders, you see the $3.7 million, and I will just advise the members of the committee that this is the Georgia Trauma Commission's proposed budget, so they don't vote on the final until you all approve our final allocation. And again, it's very similar from year to year. The commission does have 7 committees made up of stakeholders from all of these groups that receive funding. So all of the stakeholders have a say in how the funding goes. And the commission 2 years ago updated its bylaws so that the committees don't even have to be chaired by commission members. And it's a way to really get more engagement in the committees and more of the stakeholders present at the table. It's been very successful for us. So the EMS money, the $3.7 million, that's really divided up among 3 primary programs. One is called AVLS, which is an automatic vehicle locator system. So it enables the services to know where the trucks are at any given time. It also provides a Wi-Fi service so they can transmit information to the destination hospital, which is very helpful not just for trauma patients, but also for patients having stroke and heart attacks and things like that. A huge chunk of this money goes towards education, and I know you're all very well aware of the workforce shortages, and a lot of it is for licensure, first licensure education to get more paramedics, EMTs, and even first responders, hopefully in the trucks and taking care of the patients. And then as a way to sort of give some money to our 911 zone provider ambulances for their share of readiness for caring for trauma patients, the commission does EMS equipment grants. So these are typically equipment that would be involved in caring for trauma patients. And then you see the bulk of the money is distributed amongst our 33 trauma centers and 2 burn centers across the state. And those buckets are largely in trauma center readiness, which can be anything from physician and subspecialist call pay on down to the trauma center's injury prevention program. I will say that call pay, and you all again are very well aware of the workforce challenges, call pay is a huge thing right now, and a lot of hospitals are really struggling with the call pay piece. Another portion of that is uncompensated care. So we do provide a bucket, and you see the line item above that is a $50,000 line item. We actually pay a third party accounting firm to validate uncompensated care claims. And then a small portion is towards trauma registry support, which is essentially the database that all of the trauma centers must warehouse in order to capture data for the trauma patient population. A couple years ago in the amended budget, we allocated over $3 million towards a statewide, what we call risk-adjusted database. So what that does is enable us to look at outcomes across centers, and it looks at the patients very specifically. So in other words, a patient who is a gunshot wound might have a different outcome if they have, comorbid conditions, diabetes, prior stroke or heart attack or something like that versus an 18-year-old who's very healthy. So the risk-adjusted database takes those factors into consideration and really enables us to look at that. And that's all done by Georgia has a great collaborative of all of the trauma centers, and they get together and they look at this, and it enables us to really help them. They help each other, and they share best practices across the system. So that's been a very successful program. And then the line items that you see above that are essentially just, besides our operations, are just other contracted things that we fund. We do keep a line item in there for injury prevention as things come up, even though, as I mentioned, readiness for the trauma centers is really a huge portion or not a large portion of what they spend their readiness funds are, but essentially the trauma centers are really the ones out there doing the injury prevention piece. We do partner with our DPH colleagues. We are administratively attached to DPH, in case I did not mention that at the outset. And then we are, one of our responsibilities is the oversight of our foundation to raise funds for investment in the system. And I will say that we've had a huge transition within our foundation. Our foundation, with the untimely death of our foundation chair, Dr. Fred Mullins, a couple years ago, we have a new chair, and we're getting the foundation back, getting its feet underneath of it, recruiting board members. So we look forward to the foundation's contribution in the future and really getting that going. And then again, one of our funding mandates is the up to 3% for our colleagues at Department of Public Health, Office of EMS and Trauma. And I think in the effort to keep it short, I'm happy to take any questions.
Yes, you do have a question. Chairman Hawkins, you have a question?
Yeah, a question about the AVLS system. Are we contributing money and helping the private 911 ambulances also with this?
This is for anyone who is a zoned 911 provider, so that could be county
or private.
Correct.
Good,
Yeah.
good, good to hear. Thanks.
Yes, sir.
Are there any other questions? My question was similar to his about the ambulance services and what we have. I know we had some in rural Georgia that just went away and put a hardship in some of these communities. And the other, how many exactly, I know you said it, but I didn't write it down, how many trauma centers do we have, and how many are south of Macon?
Not many south of
I know.
Macon. Thank you for that. We just, one of our, it's 33 with 2 burn centers.
Okay.
And I do think one of the things that you may see when the commission approves this final budget, and as I mentioned, we have some monies for specific tasks and projects. One of those huge projects that we just completed in January, which was from last fiscal year, we had the American College of Surgeons come do a full trauma system assessment and a role-focused review. The first time the American College of Surgeons has ever done anything like that. And we had we were supposed to have it at Lake Blackshear, but they closed prematurely due to some issues. So we had it at Callaway Gardens, so it was at least in that area where our southern stakeholders could actually get to, and we had a huge turnout of over 125 people and many folks online. So we're trying to figure out what are some ways we can not only recruit, but retain. And our colleagues at DPH, they are the regulatory entity essentially over the trauma centers. We think that, certainly in Southwest Georgia, where there are a lot of counties without even a hospital, it's going to be really hard to recruit trauma centers in that environment. But we really need to focus on the transportation piece. What does that look like? And that's why the American College of Surgeons consult was so helpful. They really, we should get that final report, sadly, after the legislative session is over. But you'll hear a lot about it next year as we tear into that sort of over the the next 9 months or so and come up with some plans and what might actually work. But we expect to get that report in April. And the commission the commission meets on March 1st, and to that end, about hospitals just in South Georgia in general. We did a study back when I was on the stakeholder side in my time at Children's Healthcare of Atlanta and Grady, looking at not trauma center data because, we have that. We know the trauma patients that are treated at the trauma centers, but what we don't have is data on what patients and what does that profile look like of patients that are treated at non-trauma centers. So there's a well-known researcher in Florida that has looked at this for Florida. We've replicated their process back in 2013, where we looked at using the discharge data set and did a crosswalk to the trauma, what we call the injury severity score, so we can kind of tell how sick they were. Was it just a minor trauma, or was it a really sick patient that either didn't make it to definitive care because they had a bad outcome, they died. We just replicated that study again, doing the next 10 years. It's a longitudinal thing. You don't, do it year by year. So it'll be really exciting. He's presenting that on March 1st. And that will enable us to see, can we identify some of those centers in South Georgia that are treating the trauma patients, and then how can we maybe stand them up? We know we're not going to yield level 1 and level 2 centers in South Georgia, but we may be able to get some level 4. And as long as we can maybe get them to stand up as a level 4, then they're connected in the system. We can spend money on education and make sure that their staff are ready and prepared to take care of them when they get them.
I do recall several years back, Archibald was a level 2, I believe.
Mm-hmm. Correct.
And we do need it. I mean, there's a lot of injuries in our surrounding area, and so I appreciate that we're looking at it. Thank you very much. I don't see any other questions.
Okay.
We appreciate you very much.
Thank you, ma'am.
This concludes our business, and we are adjourned.
No, all yours.
And just so that you know, we are not going to meet. Our 3 o'clock is not going to happen.